where you are, by the way.
Hello, how's it going, guys?
Hello, Ori.
Hello, I'm on vacation, my first vacation of residency, trying to
Amazing.
find a power outlet. I'm gonna plug you guys in, but I have a fun case that is
Amazing.
perfect for 20 minutes.
All right, I love it. Ori's an intern at UCSF who's actually a neurology prelim who had the privilege of meeting just a couple of weeks ago in person. Ori, because we're moving real fast, while you find a place to plug in, do you want to just start off with the chief complaint?
Sure. Melena and BRBPR.
Amazing. So this is not an uncommon place for an emergency room initial triage. And the key question that often happens is you want to glance at the vitals. And the reason I'll be glancing at the vitals is because I'm trying to determine whether this is a significant presumed GI bleed or not. But the truth is that both these concerns, melena and bright red blood per rectum, can easily mislead us. The temptation is to say that the BRPPR, the bright blood per rectum, is blood. It may not be blood. It may be red tinged something. It may be red tinged stool because of something that the patient ate. It may be blood, so it may not be blood. It may be red tinged something, or it may not be coming from the rectum. It may be urinary bleeding or gynecological bleeding. The same is true of melena. All we know is there's something black or darkish, and it may be because the color is changed by things like iron and bismuth, as Mario just said. So there's no way that you won't assume this is a GI bleed of some kind, but you have to step back and say, am I being misled by a substance because of its color or by the location of where the patient thinks this is coming from? And as we'll talk about in a moment, a rectal exam will basically definitively tell us. If we start with the bright red blood per rectum, and we assume it's true that it's both correct in the rectum and it's both correct that it's in the blood, any bleeding in the GI tract can cause hematochezia. Blood can come from all the way up in the esophagus so fast that it comes right out the rectum still as bright red blood. It can also, of course, represent lower GI bleeding. The ratios are the following. If your patient presents with hematochezia, there's about an 85% chance that it's a lower GI bleed. However, the remaining 15% representing a brisk, super fast upper GI bleed is way more morbid. So in the world of hematochezia, the base rate tells you that it is a lower GI bleed, but the morbidity tells you to prioritize an upper GI bleed. How can you be confident and sway the needle from 85% to 15%? Of course, the vitals. If the patient is hemodynamically unstable, it tells you that the possibility of a brisk GI bleed is at play. However, that doesn't rule out a brisk lower GI bleed. But what's even better, the presence of melena. Melena represents blood that has passed through slowly. And slowly means it's taken a long time, which usually means it's an upper GI bleed. A slow right-sided bleed can present as melena. But if you marry melena with hematochezia, the most probable and morbid scenario is the following. A previously low-grade upper GI bleed has now become much more aggressive. And the key in this patient is to look at their vital signs and get prepared to resuscitate them with potentially blood based on their hemodynamics. So this patient needs 2 large bore IVs almost immediately just with that chief concern alone. And then the next key question with this is, does the patient have cirrhosis or not? That's the one thing that will change our management. And I'll tell you, there's another key question, but we'll save that a little bit for later. So I'll stop there and remind you of the 3 key facets of this conversation. Don't be fooled. It may not be blood. It may be something else that looks like it. Don't be fooled. It may be coming from a location, but be practical. This is a brisk, previously slow, but now brisk upper GI bleed, probability-wise. So make sure you get ready to transfuse the patient and ask yourself, could this be a cirrhotic GI bleed, which changes things in the ER? All right, Ori, back to you.
Okay, let me give you the setting and then I'll give you the HPI. So this was a Sunday morning on cards as an inpatient, and this was the sign out I got from from one of the cross cover people. So essentially this was a patient that we had. She was 46. She has she had an acute exacerbation of her HFpEF. We had diuresed her to euvolemia, and we're getting ready for her to get discharged. And this was actually the day of discharge. And I came in, and the cross cover said, "Oh, she had melena and bright red blood per rectum overnight." So I did everything that you said, Robbie, and kind of went to go see her, and her vital signs were stable, and she had no other complaints associated with the melena and bright red blood per rectum. This had never happened before. She had no history of any like heartburn or any hemorrhoids or anything like that. So this was really kind of an isolated incident. Do you want me to fill out the rest of the left side?
Yeah, I think I would go for it, please.
Okay. So her past medical history was notable for essentially a congenital or early childhood infection with hepatitis B. And she had had liver failure and kidney failure, for which she had had a simultaneous liver kidney transplant ×2. The last one being in 2000. Her liver graft was functioning well, and her kidney transplant was functioning okay. I think her baseline creatinine was like around 1.3, and it was kind of thought to be, but it was not thought to be like graft rejection at all. And she had no other past medical history. Her meds at this point, maybe I'll tell you what we were doing as an inpatient. She was getting diuresed with Bumex and had been transitioned to oral Bumex. She was on an SGLT2 inhibitor at home, and she was on spironolactone as well. She had been on aspirin at home, which we stopped when she came in as an inpatient for an episode of pericarditis, for which there was never a cause, about 6 months prior, and she was placed by an outside hospital on aspirin for prophylaxis, which we had stopped. She had no relevant family history, no relevant social history. She denied any tobacco, alcohol, or drug use, and she was allergic to contrast.
This is super helpful, Ori. Thank you so much. I'll say that the overlap between heart failure and GI bleeding is through a very common connection that happens. It's not through the conditions themselves, but rather the treatment that we do for patients with cardiac conditions. Most patients with cardiac conditions are on anticoagulation, for example, atrial fibrillation, or antiplatelets for coronary artery disease. And so often when there's a cardiology and gastroenterology tension, it's usually because of medications. But there are some associations. A lot of patients with heart failure have iron deficiency anemia because of AVMs. That's most well described in patients with aortic stenosis who have AVMs, and that's called Heidi syndrome. That's just for Maria, who's studying for her step 1 exam. The same is true for kidney disease. A lot of patients with kidney disease also have gastrointestinal AVMs in their GI tract. So what is the problem with that hypothesis? The problem is that most patients actually don't have brisk bleeding from AVMs. So we're still assuming that this is brisk because now there is hematochezia, but that could be flawed. We could have a low-grade upper GI bleed and a low-grade lower GI bleed from the same disease process like an AVM. But what I want to show you, it's hard to make tremendous progress here, and here's why. So somebody's presenting with hematochezia, again, 15% chance upper GI bleed, 85% chance lower GI bleed. What really helps you make tremendous progress is not so much the history. The history is not so helpful. The likelihood ratio of changing things, of anything on the history, is less than 7. The labs will be very helpful. If we see a BUN to creatinine ratio of over 30, we'll be very, very confident to ask GI to do an endoscopy before a colonoscopy. But what is awesome is the exam. The likelihood ratio of seeing melena or the likelihood ratio of seeing a blood clot in the stool prioritizes these two things. So if you see melena in the context of hematochezia, it's probably an upper GI bleed. If you see blood clots, that means the blood could not have been moving fast. Upper GI bleed causing hematochezia requires the blood to move fast. And here, this is going to be key. So right now, I'm really waiting for, does this patient have cirrhosis? And what does the rectal exam look like to make more progress? At the same time, trying to resuscitate the patient as we talked about. All right, I'll get back to you.
Okay. So when I went to go see her, her vitals were, so she was afebrile. Her heart rate was in the 60s. Blood pressure in the, I think it was like 95/60. And she was satting well on room air. She was in no acute distress, but was definitely anxious about what was going on. Her HE and T exam was non-remarkable. Her cardiovascular exam was also non-remarkable. Her cardiovascular and pulmonary exams were also non-remarkable. Her abdominal exam, so she was non-tender throughout, and was soft. There were definitely bowel sounds. And then she had these like well-healed remote scars from her two transplant surgeries. Her neuro exam was non-focal. Her extremities, or let me tell you her rectal exam quickly. So she showed me actually a picture of her stool, which was very dark brown. It was well formed with streaks of bright red blood in it. There were no clots that I saw. So it was a mix of melena and then just straight bright red blood. And then the remainder of her exam, she had no stigmata of cirrhosis. She had no ascites. She had no lower extremity edema and was really euvolemic and ready to go home from a volume perspective. I can go through her labs really quick. Okay, so her CBC, so her baseline hemoglobin was around 12 and she was 9.5 that morning. Her white count was normal. Her platelets were normal. Her BMP, so everything was essentially normal, except for the BUN, which was in the 40s, which was a little bit higher than her baseline. I think it was 48 was that morning, and 40 was her baseline, high 30s to 40. And her creatinine was 1.5 from 1.3. Her ALK phos was in the 500s and had been in over 400 for some time, which was thought to be secondary to congestive hepatopathy from her heart failure. She had had a liver biopsy in March, I think it was, which just showed congestion and didn't show any other pathology. And then her EKG was just normal sinus with increased voltages of the QRS complex. And then her chest x-ray was at baseline.
Oh, you're a master presenter, my friend. Thank you. So two pieces of advice. When you're working up a patient with a GI bleed, your instinct is going to be to look at the heart rate to gather the sense of severity and to look at the hemoglobin. Both can fool you. A patient with cardiac disease is likely to be on a beta blocker, and a heart rate may be blunted for that reason. So don't put too much emphasis on a normal heart rate in a cardiac patient with evidence of GI bleed. More important is to not put too much emphasis in the hemoglobin. Patients require time to become anemic after losing whole blood. This person is losing not just her hemoglobin, she's losing whole blood, everything in proportion. And only over time does the plasma and interstitial volume come to dilute the hemoglobin. So here, a hemoglobin drop of 3 in the face of active bleeding tells you that she probably has lost more whole blood than you're estimating. Where is she losing that blood? Well, you see it in the GI tract. Where in the GI tract? The melena and the BUN to creatinine ratio prioritize an upper GI bleed, which again, it's not certain it's an upper GI bleed, but it prioritizes enough that you probably need to start there because it's more morbid for a brisk upper GI bleed. So let's enter that world. What causes a brisk, or what causes an upper GI bleed period? Well, the common causes are peptic ulcer disease. Even when patients with cirrhosis, the most common cause is peptic ulcer disease, then varices, and then esophagitis. After that, you kind of take an anatomical journey through the esophagus, through the gastric, to the stomach, and through the small bowel. I'll leave them here for you to look at. What's the key questions that you need to know before you call GI? Does the patient have cirrhosis? Why? You will give the patient octreotide. You'll give them ceftriaxone, but more importantly, you have to remember not to go aggressive with transfusion because you can over transfuse them, worsen their portal pressure, and cause them to bleed even more. So 3 things are different about a cirrhotic GI bleed: octreotide, ceftriaxone, careful how much blood you give. This is in addition to the usual package: 2 large bore IVs, PPI. Okay, and of course, consent, so on and so forth. So where are we here? Does this patient have enough liver disease to cause cirrhosis? You have to think about it. For me, not enough yet. I'm probably not going to give octreotide quite yet, but certainly the alk phos in the history of cirrhosis and the history of liver disease is enough to be thinking about it. The other key question is, does this patient have an aortoenteric fistula? An aortoenteric fistula is the most morbid cause of GI bleed and occurs almost exclusively in patients who've had prior aortic surgery. The prior aortic surgery obliterates the space between the aorta and the duodenum, allowing a fistula to form. Now, this only occurs in less than 1% of patients with aortic surgery, but if they have that, I take them right to the CT scanner. Why? It's their only chance of survival. An aortoenteric, a history of aortic surgery plus GI bleed changes the management right away. You're not going into a bed, you're going to CT scan, and you're not calling GI, you're calling surgery. So keep this in the back of your mind. All right, Lori, back to you.
Okay, so I'll tell you what we did. So 2 large bore IVs. We gave her 500 cc's of fluids, and we redrew her hemoglobin, CBC, about 6 hours later, and it was 6.9. And we transfused her. We spoke with GI, and they agreed to not start octreotide. But we started PPI. And the plan was to scope her the next day, both upper and lower. So maybe I'll tell you the results of the scope at this point. Okay, so the EGD was completely unremarkable except for like some mild gastropathy. They didn't see any sorts of bleeding. And then the colonoscopy, and I'll just mention that during the prep, she essentially had like pretty large volumes of bright red blood in the commode. So during the colonoscopy, they found a 3-centimeter fungating mass, which was the source of with a overlaying vessel that was kind of oozing at the a little bit distal to the ileocecal valve.
The mass probably explains everything. You said it was a fungating mass distal to the proximal to the ileocecal valve or distal to it? Sorry, I missed that.
So it was on the colonic side of the ileocecal valve.
Yeah, gotcha. I'll share this. I think in this patient who has transplants, who's immunosuppressed, we often think immunosuppression plus transplant prioritizes infection, but transplant-related complications extend to prioritize that for sure. And we'll have to think, is this mass actually an infectious pericolonic mass due to immunosuppression? And wonder about the range of possibilities it could be. But we don't have time to speculate on that. The other disease beyond infections in transplant immunosuppressed patients is autoimmune diseases. And then those autoimmune diseases could be, most commonly is just transplant rejection. It's an autoimmune attack on the organ that was transplanted, but also a whole variety of cancers. The relative risk of many cancers skyrockets in patients with transplants, most commonly skin conditions, but also oncogenic related viral infections, HPV related squamous cell carcinoma, HHV8 related Kaposi's sarcoma, EBV related PTLD. So the range of possibilities here is extensive, and the priority is to make sure that this mass is neither infectious nor malignant. It's probably one of them. Kushal just has a great differential diagnosis of iliac mass, which I'll read: TB, histo, sarcoid, and lymphoma. And the lymphoma to worry about here is PTLD, which has a tropism for the GI tract. But I'd be really curious what happened in this case, Lori.
Okay, so we were also very concerned about both colon cancer and PTLD. And the path came back as amyloid, so essentially the next day we got the prelim path back that it was that the primary pathology was amyloid. And then we went down the different subtypes of amyloid train. And it turns out that she has AL amyloid. And so I'll give you a bit of the rest of the hospital course. So essentially, we volume overloaded her again from the fluids and the blood, and we thought that we were going to have to scan her. So we pre-treated her with steroids because she's allergic to contrast. So she ended up being in the hospital for, I think, like 2 additional weeks. And so I actually on card. So I actually got to see a lot of the kind of the heme and the GI workup for this. So the path came back AL amyloid. Heme did a bone marrow biopsy, which did not show any underlying amyloid in the bone marrow or a clonal population of B cells. And then we actually did an endomyocardial biopsy to look for amyloid as a cause of her HFpEF, which was negative, but we can talk about the kind of the sensitivity of that biopsy. And I'll just note that she had a right heart cath in May, which did not show a restrictive pattern of filling, and this right heart cath did. So suggesting that her HFpEF had also progressed as well. Yeah.
Ori, this is absolutely unreal. You went through a big journey and taught us a lot today. And I want to share one more schema, and then actually pass the mic to you to kind of put together your lessons and reflections from this case. And then we'll go to Vale to do some teaching points. But I think you're teaching us one really important thing. It's this fact. Okay. A lot of abscesses, Kushal was mentioning a great differential for things that can make a mass that are infectious in nature, and there are many of them. TB and histo are probably important. A lot of granulomatous diseases can form masses, but here's your culprit. And amyloidosis is a profound propensity for the GI tract. Almost every form of amyloid can involve the GI tract, which is why you had to do your investigations. AL, which is the most common, about 70% of amyloidosis is AL. AA, which is about 15%, can also involve the GI tract. So that's literally 85% of amyloidosis can involve the GI tract. And it can involve it in many different ways. It can cause ulcerations. It can cause dysmotility. It can cause malabsorption. And as Ori is teaching us, it can cause a big fungating colonic tumor-like mass. So Ori, what did you take away from this case? And thank you again for the rapid fire ER style presentation of a case of AL amyloidosis.
Yeah, no, this was a crazy case. I mean, I've had a couple of cases so far in residency that have like kept me excited about medicine in the kind of the day-to-day of just diuresing people and checking labs. And this was definitely one of them. But yeah, I think the mass does not equal malignancy for me was the most important thing that I learned from this case. And also gave me an opportunity to manage kind of an acute GI bleed. And then thinking about all the amyloid, different types of amyloid and how that interacts systemically. I mean, she's in a very tough spot. And even though she doesn't have a colon cancer, I'm not sure that she's in a much better spot. And just being humble as you kind of go through and when you get there at 5:30 in the morning and someone tells you that they're having bright red blood come per rectum, you know, thinking critically and not freaking out is good. Yeah.
It's absolutely superb, my friend. I hope you have a great vacation. Thank you for hanging out with us and spending 30 minutes here with us today.
Yes, this is great.
Absolutely. All right, Vale, take us home, please.
Yeah, this case was great. Thank you so much, Ori. So I'm going to share the 3 points of triage or 3 key questions that Ravi mentioned in the beginning, which were to look at the vitals to recognize a significant hemorrhage versus something that could not be like not a priority, or something like a mimicker that's not coming from the GI system, or something related to medications or pigments. And also Ravi in the chat mentioned all these LRs for some clinical signs of the vitals. Then the second question was to differentiate signs that could make us think about an upper versus a lower GI bleed, in which Ravi mentioned that the presence of melena and a bond to creatinine ratio that was greater than 7 have the highest LRs for upper GI bleed. And then 2 key questions regarding the past medical history of the patient, about cirrhosis, in which case 3 parts of the management will change: the use of octreotide, ceftriaxone, and to be careful with hydration. And then if the patient has an aortoenteric fistula or history of any surgery of that sort. So thank you so much for attending today and hope to see you tomorrow.
Y'all, still, if your mind is going at 1,000,000 miles an hour, that's what it's like sometimes in real life. So take a moment after you bounce to reflect on Vale's great recap here and write down what you learned. And hopefully we'll be able to do this again next time. All right, y'all. Thanks for hanging out.